Hello everyone, welcome to another video from Radiology, and today I am back with a very high yield yet very difficult and confusing topic. At least I found it difficult sometimes, but I am sure that after this video you will understand a very simple pattern-based approach to understand leukodystrophies, and you will be able to solve any question in any exam, as well as while reporting, you will be able to narrow your differentials by looking at the MRI and spotting the clear-cut clues in every disease. So, at the end of this video, I've included some high-yield questions as well. So do try to attempt those, and I'm sure that if you watch this video, I'm making it short, and you will be able to grasp all the concepts and get all the answers right. So let's start with basics. So first of all, we need to understand that what are the definitions for these white matter diseases. So one of the thing is leukoencephalopathy, which is a broad term, and it includes all white matter diseases. Then we have leukodystrophies, which include genetic white matter diseases specifically. And then for hypomyelination, we mean that myelin is low for the age, and then demyelination means that there is loss of already formed myelin. So delayed myelination is slow but present, and dysmyelination is abnormal or disorganized myelination. So do not confuse these terms. Coming up next, we have that how leukodystrophies damage the brain. So basically what's happening is that this is some basic level pathophysiology, that mostly these are preceded by gene mutations that leads to defective protein, and that results in accumulation of toxic metabolites mostly, and it results in myelin damage. So this is the whole story of how this leukodystrophy comes into picture. It can involve different organelles, which could be lysosomes, peroxisomes, or mitochondria. Then coming up to the diagnosis, where the radiology comes into the picture and how it helps in diagnosing these leukodystrophies. So first of all, we need to know that MRI is the modality of choice for diagnosing these diseases. And secondly, age is important, and you need to know the age of the patient. And lastly, what you need to look at an MRI while looking for a leukodystrophy. So there are some typical myelination and demyelination patterns. There is a typical distribution, as well as some clues in the progression of the disease, as well as in the clinical history. So all these 4 or 5 components will lead you to the proper diagnosis. So now coming up to the first of category, which is hypomyelinating leukodystrophies. And what is the basic MRI diagnostic criteria? It is very high yield, and it is also very critical for diagnosing, and it's very simple as well. So there are only 3 things that you need to remember: that there is no myelination progression. Okay, so if you're sitting in your radiology reporting room and you come across this MRI in which there are diffuse hypointense signals on T1 and T2 hyperintense signals involving almost all of the brain in a 5-year-old child, which means that there is no myelin. So this is the hallmark disease of hypomyelinating leukodystrophies, which is known as PMD. And now let's see the other types and the features of PMD as well as the hypomyelinating disorders. The types including PCD, PMD, then we have PMD-like disease, and we have Pol3 related disease, then we have hypomyelination with congenital cataract, hypomyelination with atrophy of basal ganglia and cerebellum, and hypomyelination brainstem and spinal cord involvement, and leg spasticity. So when it comes to hypomyelinating disorders, the main disease that should come into your mind is PMD. This is X-linked, and rest of the diseases are mostly autosomal recessive. Only the hypomyelinating disease involving basal ganglia and cerebellum is sporadic. And in PMD, what you need to understand is that there is complete myelin absence, and the patient will be presenting with nystagmus, ataxia, and dystonia. And since it's an X-linked disease, it is seen in males. So that's all that we need to know about PMD. And here is now let's see another entity in which we are going through an MRI. That's a FLAIR image, and you can see that there are hyperintense signals in the periventricular white matter, and it is not involving the U fibers. So what could it be? And it's a young adult. So when it comes to such a pattern, we are supposed to think about metachromatic leukodystrophy. When you want to remember MLD, think of it like a tiger, and the tiger doesn't have U-shaped lines. These are basically straight lines, and this involves periventricular matter as well as deep white matter, and U fibers are spared. So these are the three things that you need to remember when it comes to MLD, and it can present late in life, like in adulthood, and there can be mental retardation or sometimes regression and some other neurological signs. So these are some simple 3 to 4 terms that you need to remember for metachromatic leukodystrophy. Now let's come up to another scan, and here we are seeing a CT brain plane, and in this CT we can see that the thalami appear hyperdense, and there are some atrophic changes in the brain, and this is actually a scan of a 3 years old child. So this makes us think about some leukodystrophy, and then we come to know that this is basically gluboid leukodystrophy, which is also known as Krabbe's disease. So think of it like a crab, which is sitting on thalami and cerebellum. It's basically onset is basically in infancy, and it can be fatal by 2 years. And there is spasticity, mental retardation, and visual failure. It is the disease that is seen on CT as well. Most of the leukodystrophies are diagnosed on MRI, but this can be diagnosed on CT. So on CT, as we already have seen, that there are hyperdense thalami and cerebellum and corona radiata are also involved. And there are confluent symmetry T2 and periventricular and deep white matter hyperintense signals, and they are alternating hypo and hyperintense lines around the dentate nuclei. Cranial nerve in chorda equina enhancement is a hallmark feature of this disease. So there are many things to learn. So let's come up to a very cartoon image, and this image is including almost all the components that we just studied, that include Krabbe, which is basically sitting on thalami, and then we can see that the basal ganglia can be involved. Then we know that cerebellum is involved, dentate nucleus is involved, and chorda equina and cranial nerves are also affected in Krabbe's disease. So try to visualize this image, and I hope you will be able to understand and learn the Krabbe's disease. Now let's come up to another image. Well, actually, we're going to look at two images. So we are presented with a neonatal MRI. We have FLAIR and T1 with contrast axial slices. On FLAIR images, we can see some T2 hyperintensity, which is bilateral symmetrical, and it is actually at the posterior aspect. Moreover, there is enhancement along the most posterior, or we can say the leading part, leading edge of the lesion. So what could it be? When it comes to such picture, which is a bit similar to butterfly pattern, the only one thing that we come across is adrenoleukodystrophy. So when it comes to adrenoleukodystrophy, think of it um, like a disease in which you can see a little bit of butterfly-like pattern in the posterior aspect of the brain, and the patient might be presenting with behavioral changes, cognitive decline, or adrenal insufficiencies, and it involves splenium of the corpus callosum, as that lies at the posterior aspect. Peritrigonal white matter is involved, corticospinal tracts, visual auditory pathways are involved. And the main hallmark of this disease is rim enhancement at leading edge. So post contrast T1 image is very important. So if you are shown this image, or you are asked about post contrast T1 in any exam scenario, then you must keep an eye that it could be early. So how to remember this? I have created another visual chart for this. So if you can memorize this image, which is very clearly showing you the rim enhancement, which is basically due to inflammation, necrosis, edema, and the splenium of the corpus callosum is involved, as well as posterior white matter and splenium is involved, then we're gonna think about ALD. Now let's see another MRI, and in this MRI, basically we are seeing that the T2 hyperintense signals are more prominent and predominant in the frontal cortices bilaterally, almost symmetrically. So what could it be? Whenever it comes to frontal bilateral disease on MRI in a child, think about Alexander's disease. So think of it like Alexander the Great, and he was famous, and he was think like that he used to lead from front. So what is it basically? We have already seen that it's basically bifrontal white matter predominant disease, and it is due to horizontal fiber accumulation, and it can present in infancy, in a child, or sometimes in adult as well, and it has variable progression. So it's very simple, it's very easy. Alexander frontal cortices, that's it. And sometimes one thing that can be mentioned in the MCQs is that the child has macrocephaly. So how to remember this? I have created another visual. It is about Alexander leading from the front, and the frontal white matter is involved. Simple and clear. Now what we have next is some organic acidemias and amino acid pathies. What happens is that there are sometimes defect in intermediate metabolism of amino acids, carbohydrates, fatty acid oxidations, and these present in infancy. And how are these diagnosed is these are diagnosed on the basis of biochemical tests. And on imaging, there is myelin damage. So we will be discussing two major diseases from all the organic acidemias and amino acid diseases, which would be Canavan and phenylketonuria. So what happens in Canavan? It is basically due to a metabolite, uh, NAA, N-acetyl aspartate accumulation, because the enzyme that is needed to break down NAA is deficient. And what it makes is that it makes white matter spongiform. So white matter is degenerated and spongiform. It mostly is seen in the first months of life, and the patient will have macrocephaly, hypotonia, and it's a bit deadly. Now, how it will present is that there will be subcortical U fibers involvement early in the disease. Thalami will be involved, globus pallidus will be involved, internal capsule, putamen will be spared. So think of it like that it is involving the deeper things like thalami, globus pallidus, as well as subcortical U fibers very early. And then we come to phenylketonuria. Phenylketonuria is basically due to accumulation of phenylalanine, and the patient can present with severe mental impairment if untreated. And there are basically T2 flare hyperintensities in the periventricular or subcortical white matter, and U fibers are spared. So these are the two things. Now, when it comes to the diagnosis, in Canavan's, MR spectroscopy plays the very critical role, in which there will be peak of NAA. So when it comes in exam, there are mostly 2 to 3 clues mentioned, like macrocephaly is mentioned, sometimes hypotonia is mentioned, small child, infant is mentioned, and there is some hint about NAA, N-acetyl aspartate. So just when it comes to Canavan, think about N with 3 A's in the name. So NAA should blink in your mind. So this is the clue, and here is another image for remembering these two. So these are simple and easy, and often come up in exams. Now let's come to another entity, which is about mitochondrial disorders. These include 4 to 5 diseases, including Leigh disease, MERRF, MELAS, and Sayre disease. So what is happening here? That Leigh is a common one. The you can say the phase of the mitochondrial disorders, and this is basically a disease in which there are T2 hyperintense signals involving caudate nuclei and dorsal brainstem. and there is restricted diffusion in those areas as well. And when it comes to other diseases, let's have a look. So this is a very cute table, and it's simple and highlights the key facts. So in Leigh, as we already seen, that there is basically lactate doublet, and it's Leigh for L, and there is lentiform nucleus involvement, as well as there is lactate peak. So LLL. That's a simpler thing to remember. When it comes to MELAS, in MELAS, basically these are cortical lesions, and the symptoms are stroke-like. And this is due to lactic acidosis. And the key thing is that stroke, when we see stroke in an adult, it's basically in vascular territory. But in MELAS, the stroke-like lesions, the cortical lesions, are not respecting the vascular territories. So this is important, and there is appearing, disappearing, and reappearing of the lesions. Then we have MERRF, which is basically myoclonic epilepsy ragged red fibers, and basal ganglia is important and is involved. Then we have Kearns disease, and in that there is ataxia, ophthalmoplegia, retinitis pigmentosa. This is a classical triad, and on CT scan we're going to see basal ganglia calcifications as well as T1, T2 hyperintense signals in cerebellar white matter. So this is all about mitochondrial diseases, and now there is a high-yield pattern table to summarize all the diseases that we just discussed. So just have a quick look at it, and then I have included these questions that I highly recommend that you try to solve. These are very high yield and very similar to the questions that come up in the exam. So have a look at these. The answers are here, and last but not the least, I really recommend that you try to watch this video, especially if closer to the exam and you do not have time to understand these leukodystrophies by yourself by studying or reading. And like, subscribe, and share. And there will be more high yield and difficult topics coming, especially for the radiology exams. So stay tuned and take care. Bye bye.